Thank you, Dor. Thank you for the invitation to speak, and I've enjoyed my time in Israel so far and will continue to enjoy my time in Israel. Dor asked me to speak about medical approach to weight regain. As an internist or obesity specialist, this is becoming, unfortunately, one of the most common things I see in our combined medical surgical practice. And it makes sense, certainly, that medicine and surgical approaches should work together. We do that in every other disease we treat. We use multiple modalities, and this is one that is showing itself to be most useful in combining our modalities. I do receive support from Aspire Assist. It has no relevance at all, however, to this presentation. I'm going to give you my background and approach up front, so I'm going to be supporting these bullet points during my presentation, but I wanted to tell you what I'm going to say right up front. In my view, the determinants of post-bariatric surgery weight regain are largely identical to the non-surgical weight regain, with the notable exception of anatomical failure of the surgery. All patients presenting with weight regain should undergo a comprehensive medical evaluation to assess the determinants as well as interventions as indicated. We think about the right patient, the right time, and the right treatment. We're not there yet, but that's hopefully where we're going. Even though psychosocial and lifestyle management strategies make intuitive sense, current studies have been inconclusive regarding meaningful improvement in weight loss. And I'll just summarize some of that data for you. Most of the talks after mine are going to drill down into diet, psychology, physical activity. I'm going to give an overview of that, and hopefully, and they will give much more details and hopefully more directions that we may be going for better outcomes. Lastly, although data is extremely limited, pharmacotherapy may be one of the most impactful treatments available. So I'm going to talk about this, unpack this, if you will. The whole idea that weight regain after bariatric surgery is similar to weight regain without bariatric surgery, the opposite. I wanted to go kind of to some historical data that goes back from 1990 to 2000. This is data from Reno Wing, who looked at a whole bunch of behaviorally based weight loss studies. And what you see is, on average, after the first year or so, individuals start to regain weight. And if you look at the amount of weight regain, George just went over how you calculate weight regain. I just basically used what he talked about as well. If you take nadir weight, and that would be your total weight loss, if you then look at how much weight you regain from nadir, it turns out to be about 31%. So one regains about 31% of what their total weight loss is after 2 years. These are behavioral studies. If you happen to look, again, historically at the SOS study, I just looked at the gastric bypass. It has the fewest subjects, but the most relevant for today. If you look at the gastric bypass, and they're losing about 38% of their body weight. If you look on average, the amount that they regain, and you look at the weight regain versus total weight loss, you end up with about 34% weight regain in that group. Very similar, as it turns out, almost identical to what you would see with non-bariatric surgery. Of course, that's only looking at averages. This is data that we did quite some time ago and published, and there's individual variability. So average weight regain, of course, is not quite as specific as you'd like to know. We happen to look at data from our group, which looked at 300 individuals over 7 years, and what you see using a histogram is that most of our patients either maintained weight or regained about less than 20% of their weight, much better outcome than what I showed you from the SOS. But you have individuals who continue to gain weight over time. Our average weight gain was 23%. If you look at the median, it's probably more like maybe 20% weight regain, better outcomes than that SOS. And if we look even further regarding weight regain, and you start looking at lab study, which I'm going to show you several studies. Dor looked at labs as well. We start looking at weight trajectory. And this is, of course, when we see patients, we don't want to talk about means or averages. We want to talk about the variability. And And this is another way of looking at variability, is to look at weight trajectories after weight loss surgery. And they came up with 6 groups that they happen to put into a trajectory. And you see some individuals do lose weight and keep it off. However, it seems like most really do have some weight regain as time goes on. I think the future of this field is to do better computer modeling and looking at trajectories so that we could start identifying individuals within 6 months to 1 year. That's where it seems like these trajectories start to separate out, so we can intervene even earlier. So that, I would think, over the next few years, we'll have algorithms and trajectories that we as clinicians will be able to use in order to predict better who's going to gain weight, looking at weight. But staying on this whole idea of predicting how someone will do, the LABS study, which is this is observational study from the United States, where it wasn't randomized, it was just observational and prospective, gave us a huge database to try to understand, can we identify individuals who are likely to regain weight or not do quite as well. And in this study published in 2015, the LABS group looked at a whole host of biometrics and psychosocial behavioral variables, as you can see. And with such a large database of thousands of individuals, they hoped, as well as I did, that they would identify predictors of individuals who would not do as well or start to regain. And I just took the summary statement from their article. Despite the relatively large sample size, the breadth of baseline factor analysis data collected, a predictive model to adequately explain variability in weight change did not emerge. Despite looking at all of these variables, they were unable to identify prospectively, that is preoperatively, how individuals did. Well, to the benefit of this group, they then looked at post-operative variables, and it may be hard to read. I apologize. You don't actually need to read it. What you need to look at is how many variables. How many variables they ended up looking at towards the left. They had weight loss practices, they had alcohol, smoking, illegal drugs, eating behaviors, and other problems. And they then found only 3 variables predicted 16% of the variability. That's not even that much. Out of all these variables, only 3 emerged that predicted 16% of the variability, and that was a weight loss between 38% and 24%. But the 3 variables should be very familiar to you because Dr. Dicker already mentioned them to you from the National Weight Control Registry. Weigh yourself on an ongoing basis, stop eating when feeling full, and stop eating continuously throughout the day. And they've been shown repeatedly. So whether I had a patient who had surgery or not, I would be telling them the same thing. And those are the variables that came out. So how do we start to approach individuals who come in with weight regain in some organized, structured fashion? This is what we do at our center at Northwestern. Patients are referred or self-referred from our bariatric colleagues with some sort of weight regain. And the first thing you want to do is to define the threshold. And Dora went over some of those differences in thresholds, whether it's 10% weight regain, 20% weight regain. We use 20, 25% is really getting our attention, along with the medical problems that emerge. That then gets them a comprehensive evaluation. And we start off with a detailed weight history and understanding their life events, which I will show you in just a bit. And then we very structurally and in a very organized way try to understand all of the different variables or different reasons why someone may be gaining weight, and then intervene accordingly. Again, in the talks that will follow, you're going to be hearing all about this. So my talk is really more of an overview of this, and in the other talks, you'll be hearing more details about this. I will end, though, speaking a little bit about anti-obesity medications, because that I don't believe will be covered later, at least in this symposium. So let me first talk a little bit more about understanding life events, and it supports my idea that weight regain after bariatric surgery is something we see all the time, whether you have surgery or not. And I'll show you what I mean by that. In our program, for the past 20 years now, we have asked individuals to graph their weight according to different life events. This is just an example of what it may look like. I found this to be very useful in connecting with the patient. It highlights the whole essence of narrative medicine, which is storytelling. It's an autobiographical approach, so the patient tells you their story about how they gained weight and what those life events were. It also helps with pattern recognition, and also it's a patient-centered approach. I'll be saying much more about this approach at the symposium tomorrow night at 6 o'clock, where I'll be talking much more about the graphic approach. So I want to show you just some examples so you understand what I'm talking about on how it's really the life events that appear to cause the weight regain. Not that physiology is not important, which was just gone over with Dr. Dicker. It's very, very important. But it's the life events that seem to bring out the differences in coping and appetite and changes in physical activity. This is just an example of you see their weight gain. This is done by the patient, how they're gaining weight. They were single. They developed pregnancy. They had a divorce. These are all things that cause weight gain, which then resulted in weight loss. Tried all things like Weight Watchers, Jenny Craig, Nutrisystem, all these approaches we have in the United States. Weight Watchers, of course, is international. And then they had weight loss surgery here, followed by weight regain, not because they said their PYY or their leptin levels were having a problem with. It was because of the stress in the family. That's what brought out the changes in the metabolic adaptation and changes in diet and physical activity, sleep, and so forth. And that's what caused the weight gain. You know what? She started losing weight again, just like she didn't even have bariatric surgery. Here's another individual, different pattern completely, who started gaining weight, reached 330 pounds, had bypass surgery, had plastic surgery, that says tummy tuck, and then gained weight because she had child number 1 and child number 2, which are biologic causes to weight gain, which is pregnancy. Here's another pattern of long weight gain, had bariatric surgery, and ended up retiring, and then changes probably in physical activity, leisure physical activity, eating, and so forth, and again, causing weight gain. And here's just the last example of someone, a different pattern completely. It says married, unhappy, divorce, remarried, ended up having a lap band, and here patient's gaining weight again. So as an internist, I'm just so impressed that these patterns reemerge regardless of what the intervention is. It's really one's life events and how they cope in the resiliency that seems to have the greatest impact or a major impact on their long-term weight loss. So when I'm evaluating a patient after doing all this, I drill down and take a much more detailed history. So when I go down this pathway, which is medical, I ask clearly, have they been pregnant? Is it a woman that's gone through menopause? Are they on weight-gaining medications? Did they stop smoking? These are all physiologic causes of why people gain weight. There are rare endocrine causes, but you don't want to miss it. I think there was a retrospective view quite some years ago looking at Cushing's syndrome in patients that regain weight. And you're probably talking about 1% of individuals, but it's not zero. So you don't want to miss that. Hypothyroidism is not a common cause for a lot of weight gain, but again, you don't want to miss it. And then there's a lot of the adaptations that Dr. Dicker already went over with you. Regarding weight gain medications, that's something we don't want to miss. And I have a list here. Not all these medications may be available in Israel, but it is very, very helpful to take a detailed history regarding medications in your individuals that may not have been on those medications when they underwent surgery. And these are the categories. The most common really are the anti-diabetic agents as well as the neuroleptic agents. And when possible, you want to change those medications out for those that are either weight neutral or causing weight loss. And that's something we do automatically when we see our patients, is swap out medications to the best of our ability to prevent further weight gain. Everything I have listed here is a summary of the literature, by the way. These aren't just things I'm making up. If you do a good literature search, what you come up are all these variables that have been associated with, in one study or another, with weight gain. Even though the lab study was unable to identify it in a organized way, different studies, whether it's retrospective or smaller cohorts, have identified these types of eating behaviors that we try to assess in a formal way and then intervene in. Grazing and nibbling and mindless eating. They're no longer paying attention to the restraint of their surgery. High energy density foods, consuming high calorie liquids and soft textures that go down easily. Loss of dumping syndrome, so they start gravitating more to high sugar foods. Loss of control over urges, binge eating, and reduced vigilance. When it comes to physical activity, again, you're going to hear more about that. This is just different ways it's been summarized in the literature. And it all really summarizes they're not getting enough physical activity. And you just heard from the Biggest Loser data that it's that increased physical activity that really was the difference between those who are successful versus those who are not successful in keeping their weight off. When it comes to psychosocial issues, variables that have been identified in the literature are depression, anxiety, stress, disinhibition, a loss in dietary restraint, loss of conscientiousness and vigilance. Change in cognitive function has also been identified, which is very, very interesting to appreciate, and then substance use. And then lastly, other behavioral psychosocial issues that are unique to the patients who have undergone bariatric surgery. And that's frequency of postoperative visits, attendance at support groups, completed band fills, and distance from weight loss center. These are all determinants that have been seen in literature that may affect weight regain. So what do we do about it? And I just want to summarize my understanding of the literature. And I wanted to start off with two reviews that were published a while ago now, 5 years ago. The first one by Rudolph that looked at postoperative behavioral management in bariatric surgery, systematic review. Rudolph found 8 studies that identified behavioral lifestyle interventions, 5 of which were randomized controlled trials. And I took the summary statement from the review, which I put in quotation marks. Across all studies, patients in the treatment group showed a higher weight loss than patients in the control group. However, differences did not reach significance in any samples. So despite the interventions, the outcomes were really not significant. And also, which I'm going to show you again in another review, is that the variability is really quite large. They started either 6 months after surgery or 3 years after surgery. The duration was 2 months to 3 years, and the intervention also changed, not only in the leadership, and that was who was giving the intervention, but also the content in the intervention. There's no standard of care whatsoever, at least at that time, and it's actually even till today. There was another review by Beck looking at psychotherapeutic interventions. And you could kind of read it yourself. I won't read it completely, other than a modest beneficial effect on post-surgical weight loss with an overall effect size of 0.18, which again is very, very modest. So the interventions to date, at least here, have really been not as effective as we had hoped. I had the opportunity in my group, John will recognize current obesity reports there, in which we updated the data, and we found 7 randomized control trials at that time. None of them focused on prevention of postoperative weight regain. They all focused on weight loss, not weight regain. We also found variability in the timing of the intervention, the duration of the intervention, the follow-up period, and the outcomes. And our conclusion, which I'll just read here, is that currently designed lifestyle interventions have either no effect or are modestly effective in enhancing further weight loss and influencing lifestyle-related behaviors among post-bariatric surgery patients. Now, in the speakers that follow, I hope this will be changed and it'll be much more effective. But as much as we try, our outcomes have not been as effective as we would like them to be. So since the study that I did another lit review, and I've captured, I believe, most of the studies, if not all that have been published. I may have missed some. And I showed them here from 2015 to 2017. There's, I guess, 5 of them here. And I won't read all of them for shortness of time, but as you kind of scan them with your eyes, if you look at the intervention, they're all different. Some are just exercise. Some are are cognitive behavioral therapy. Some of them are dialectic therapy. Now we're introducing acceptance-based therapy. And I think these are wonderful pilot trials to try to understand what intervention, when to intervene, how to intervene in a pilot way may be effective in preventing further weight gain or intervening with an individual with weight regain. The outcomes, I think, are modest. Here, there's not much difference at all. Here's a weight loss of 1.6 kilograms. Here's a mean weight loss of 5%, but only 11 individuals completed the treatment. There's more physical activity, increase in functional ability. The one that really was very helpful, I think, was using portion-controlled foods, something we use in the medical side all the time. These would be called meal replacement products, in which weight loss in 4 and 6 months were 4% versus very little weight loss at all in the control. So that's going back to basics, calorie and portion-controlled foods to help individuals recalibrate their eyes about how much food they actually should be eating. May be very, very helpful. This is one, you'll see this again later, probably during the physical activity presentation, but this was just published and I wanted to present it to you in the British Medical Journal, Open Journal. And you see overall, looking at a systematic review, there is benefit from physical activity, whether you start half a year after surgery or 1 year after surgery or 3 years after surgery. All of them are favorable to causing more weight loss. However, I think the main benefit of physical activity is not really weight loss, right? It's functionality, it's cardiovascular fitness, it's maintaining lean body mass, agility, balance, so forth. That's really what physical activity does. It's not so much to lose weight, but it did help individuals lose weight, which supports what you heard earlier from Dr. Dicker in the Biggest Loser, is that it is the physical activity and the burning of calories that was most effective. I did want to end up, let me go back here. So the summary of interventions to date, from my view, is that there is significant variability in the timing of intervention, the intervention itself, which is the content and the delivery, the duration and follow-up, outcomes measure, and patient eligibility. I mean, you name it, and there's variability in all of these studies. The number of patient studies generally small. There's very few randomized controlled trials. There is no standard model of care. So if you're going out and starting a weight loss program right now, which had a bariatric surgery component, and you wanted to put something in place to deal with weight regain, there is no standard of care. We do not have that in place right now. And the summary, of course, is more research is needed. And that really leads me to the last point I want to make, which is the combined use of pharmacotherapy with bariatric surgery. For the first time now, at least in my practice, which goes over 35 years, at least in the United States, I know not all of these medications are available here in Israel or other parts of the world, but at least in the United States, these are the medications that we have available, that we now have experience with, going back to 2012, 2014. They all have different mechanisms of action, which I won't go over in detail today. You've already heard about liraglutide from Ador, who mentioned it in the 3-year scale trial. But they all have different mechanisms of action, other than orlistat, which is a GI lipase inhibitor that works in the gastrointestinal tract. All these other medications work in the brain, either in the appetite center or through the reward center, and affect appetite. So they affect the liking of food, the wanting of food, the hunger, fullness, and so forth. In all of these studies, I'm sorry, this jumping around. Okay. There we go. That's wrong. I apologize. All of these drugs have been studied in phase 3 randomized trials, and I just showed them all here. That's placebo, orlistat, lorcaserin, phentermine, topiramate, bupropion, naltrexone, and liraglutide. Those are the colors. And in all of these different trials that have been done, some in the U.S., some of them are global trials, and if you look at 5% categorical weight loss, that's what this is. That's the percent of subjects who lost at least 5% of their body weight. That's the criteria for approval. You could see in every one of these studies the active group lost more weight than the placebo and did so at least 2 times more or so times the placebo. So all of them are effective. Some of them are more effective than others, but they all seem to work. And it would make intuitive sense that we would now use these medications in patients who have had bariatric surgery. And this is a summary of the world literature on use of medications in patients with bariatric surgery. There's 4 studies that I was able to find. All 4 are retrospective. The number of subjects vary from as small as 33 to as much as 319. The medications used vary. It reminds me of the data I just presented to you. This group used phentermine or phentermine and topiramate. These are 2 different drugs. And you can see the weight loss at 12 weeks, which is really actually quite impressive and similar to what we see in patients who did not have bariatric surgery. This group used 15 different medications because it went back many, many years before these other medications were approved. That's why there's so many. And you can see the categorical weight loss of 5, 10, and 15%, which is actually quite impressive. Again, that's multiple different medications. This is the only study I'm familiar with that looked at liraglutide retrospectively, 33 individuals, and the weight loss was very respectable, like we see in patients without bariatric surgery. And then lastly, a group from Cleveland Clinic, Zebeda, looked at 209 patients, looked at 4 different medications, and they lost 37%, lost at least 5% of their body weight. So this is, I think, a biological treatment for a biological problem, which is weight regain and a change in physiology. It makes perfectly good sense to me. We need prospective studies just to understand which medications and when to intervene. So I wanted to, it's just bouncing around. Okay, I just wanted to summarize with a guideline published by Luca as well as our host, Dr. Dicker, as the first 2 authors from the European Association of Study of Obesity for post-bariatric surgery. And it summarizes really the way I see it as well. And that is weight regain after bariatric surgery, a result of multiple variables. The evidence level is 3, and the grade of the recommendation is D, which means you can't get much lower than that because we don't know enough. Enforcing and sustaining healthy lifestyle facilitates weight regain prevention. We think it's true, but the recommendation is also very low. This really summarizes what I just presented. Congratulations to both of you. And lastly, adding anti-obesity drugs and or redo operations may halt weight regain or create further weight loss when applied optimally. It's level evidence 3, which is exactly what I presented, and the recommendation is D. I think you guys are right on regarding where we're at with these recommendations. So lastly, just to summarize, weight regain occurs among surgical and non-surgical patients with multiple similarities. I hope I presented that to you. Recommend that patients undergo a comprehensive evaluation to identify etiology of weight regain and intervene with more targeted approach as much as we possibly can. Currently available treatments using behavioral and psychosocial interventions lead to modest improvements. We need much more research. And lastly, pharmacotherapy appears to be promising and should be considered as an adjunctive treatment, but we need more studies to understand how and when to use them. So thank you very much.